course, thank you. So good evening all. Welcome all to this evening's Health and Adult Social Care Policy Accountability Committee. My name is Councillor Natalia Perez. I'm the chair of the committee. Before we make a start, I would like to remind us all of a few housekeeping points. This meeting is being live streamed to the Council's YouTube channel. By participating, you are consenting to being recorded. Please, can officers and guests introduce themselves when they first address the committee for the benefit of people that may be watching remotely. And also, if the alarm sounds, please leave the meeting in an orderly fashion by the staff fire exit, which is behind to my right. Officers will direct you to the assembly point in Riverside Gardens. So agenda item number 1, apologies for absence. So I know we've received a few apologies this evening. So we've had apologies from Councillor Rosenberg, Councillor Roby, Lucia Boddington, Victoria Brignall, also Keith Mallison, and apologies for lateness from Councillor Emma Absorb. That's it, no? In terms of apologies? Great. Okay, thank you very much. Agenda item number 2, declarations of interest. Are there any declarations? Okay, thank you. Agenda item number 3, minutes from the last meeting, which was held on the 31st of January 2024. Minutes are from pages 4 to 11 of the agenda pack. The members agree to the minutes of the meeting and matters arising. Yes, do you agree to them? Okay, thank you. Are there any matters arising?
Yes.
Oh, yes.
How did you guess it was going? I'm not trying to chair the meeting from the side. I should also say something about this is very echoey. There we are. It is as it is. Yes, just if I may slightly abuse the mention of public health in the matters arising, just to let you know that Dr. Lang and I have been very concerned to read reports in the press of the amount of E. coli bacteria that there is in the River Thames at the moment, and that it is unsafe. That rowers are being warned of all sorts of measures to take, particularly people who are coming up to do the boat race this weekend, have been warned all sorts of measures that they need to take to protect their health. And we have written today to the chief executive of Thames Water, expressing our horror, quite frankly, at the revelation of how filthy and dangerous the Thames has become. This is because Thames Water consistently pumps sewage into the river, consistently, not simply on dry days, but all the time. It did 7 hours yesterday by Fulham and Chelsea. It did 6 hours today by Fulham. It constantly happens. And so it's just to let you know that we've written to Thames to ask them not just to express our horror, but we've asked them to give us a commitment that they're not going to risk public health any further by dumping sewage in our river. I'm not sure what Thames will be able to do at this stage. It is quite clear there has been a total failure of regulation, and that's because the regulatory framework which is set by the government has also failed. But Thames Water cannot any longer be allowed to get away with mealy-mouthed, oh, we're doing our best about this, when people who are rowing in the river, and one of our countries and one of our most loved annual sporting activities, which is the boat race, are being put in danger as a result of their dereliction of duty for so long. So we've written to them today, and we'll report back to the committee and let you know what it is that they say, but we'll also be publicising that. Thank you.
Thank you very much, Councillor Coleman, for the update. Jim?
Thanks. On a different matter, at the last meeting, we asked that a letter be sent to Imperial about monies for the refurbishing of Charing Cross floor by floor. And we said we would do that because it seems to have dropped off the agenda, but declaring an interest, having been a patient of that hospital recently, I have an interest in having a functioning hospital. Did we get a reply? Because the hospital is in a state of decay.
Thank you, Jim. I can actually confirm that a letter was sent, and I understand that we have received something, but it was yesterday, so it will be circulated with members of the HASPAC in the coming days.
Again, can we write back after that? Because it is quite important that we don't just take it as a fact of nature that hospitals are allowed to fall down, to be in dereliction, because it's one of the key institutions in our area used by so many people. So I think we need to keep pressing on this. The hospital needs money. Everybody knows that. And we need to keep asking, when's money coming? Give us a date and an amount of time.
Absolutely, totally agree with you, Jim. And Councillor
Yeah,
Coleman?
Chair, with respect, writing to Charing Cross Hospital. So did you want to speak, please?
Thank you. Just on that, I can sort of concur with Jim, having been a very recent patient at Charing Cross, which I could do without. Could we possibly also, the whole committee, actually have a copy of the letter that was sent when you send us the reply? So we've got some idea of what we've actually requested. Would that be possible?
Yes, of course, that is possible.
Thank you very
We'll
much.
circulate the letter and then we'll circulate the reply as well.
So Chair, thank you very much. Just as I was just going to say, Jim, your letter, a letter to Charing Cross Hospital saying that we think it ought to have the money to spend on the desperately needed refurbishment is, I'm sure they'll be welcome. They'll be happy to see it, but of course they aren't the people who were refusing to give them the money. There is no money for floor-by-floor refurbishment for Charing Cross Hospital. There is not the money that's promised to refurbish by 2030. There may be a small amount of money coming their way, a small amount of money to prepare a business case, but there is not the money that was promised. And anybody who tells you that they've been promised the money is simply not telling you the truth. So I would suggest, if you wish them to get the money, rather than write to the hospital, which was as keen as you are to get the money, and for St Mary's and for Hammersmith Hospital, but you might wish to write to people closer to the government.
I'd be quite happy for that, because I've forgotten the exact details of discussion at the previous meeting. But what we do need to know is that we have to wear away as much as we can to say money was promised, the money is needed, the hospital is in disrepair on some key areas, and we simply are not just accepting it as a fact of life. There's a responsibility needs to be taken by the Department of Health to forward the money.
Thank you, Jim. Noted. Yes, we'll do that. Let's move on then to agenda item number 4, same-day access to GP primary care. Thank you very much for the speakers coming this evening. We actually discussed this topic as well 2 or 3 weeks ago at the Joint Health Overview Scrutiny Committee. So it's good to have a focus on an area. So thank you this evening for coming this evening.
Thank you, Chair. Would you like us to introduce ourselves so people are aware who we are?
Please. Yes, please. You could introduce yourself. That'd be great.
So my name is Dr. James Kavanagh. I'm a GP in Hammersmith and Fulham at Brook Green Medical Centre, and I'm the Borough Medical Director. Previous to that, I was the chair of the CCG for the borough for about 5 years.
Hi, I'm Linnell Hales. I'm a lead on access and primary care strategy at North West London.
And I think everybody knows me. I'm Debbie Parkin. I'm Assistant Director of Primary Care at Hammersmith and Fulham.
Before we start the questions, I've thought it might be useful to give a summary of where we think we are from our point of view, and that might tee us off into the conversation. Is that okay, Chair?
Yes, please. That's welcome. We've also included as part of the agenda for this evening the papers that were submitted for the Joint Health Overview Scrutiny Committee, which also gives background information, but of course an update is welcome. Thank you. Okay, so
before coming to this meeting tonight, I've spent a lot of time reflecting on all the different things that have happened over the last few months, and it's interesting how such good intentions can go so far awry. With the hope to improve access and continuity of care for patients, we've actually resulted in a lot of patients feeling that access to their GP and potentially access to good medical care has been threatened. That was never our intention. And I think, as you can see, the various members of the ICS have expressed their apologies. And I would want to reconfirm that that was not our intention. However, thanks to the extensive feedback, constructive feedback from many people, the position has changed. And tonight we will and should highlight what went wrong, because many things went wrong. But I hope this can be an opportunity for us to look ahead and see how we can build constructively from the central tenant, which is that in Northwest London, many people do not feel they have appropriate access to their GP, and we need to solve that. So I've been a GP around here for about 20 years, and before that, my parents were GPs around here for 40 years. Things have changed. When my father was a GP, he saw 8 patients in the morning. When I started in Hammersmith and Fulham, I would see 14 patients in the morning. This morning, I dealt with 52 patient contacts. We have seen a huge increase in productivity of the workforce. Northwest London has I think, an enviable reputation for introducing innovation, be it electronic, be it structures of care, or be it recruiting a diverse workforce into primary care, not just general practice. We should be proud of that. This innovation has gone wrong, but the central tenet, which is to improve access, remains. So, I think this is an ICS problem, but it's one that can only be solved at the level of place. And by place, I mean practice by practice, PCN by PCN, with the residents, with the local care community, and with any stakeholders who feel they have a place in discussing how we can use the limited resource we have effectively. So let's look at what went wrong. My belief is there was a lack of appropriate engagement at every level and at every stage of this initiative. When the ICS was formed, access was one of the key and remains one of the key priorities of the ICS. It was discussed at the boards and at the away days, but from agreeing that as a key principle to landing a contract on a provider, along the way, mistakes have been made, because if we hadn't made the mistakes, it wouldn't have resulted in the furore and the fear that my patients expressed to me and other GPs have heard. We did a top-down approach without engagement, and that clearly is not the way you manage change. We tried to roll out a model before appropriate assessment had been made of the 10 sites in Northwest London where this model of access at scale is already operating. So we have listened. Going forward, we'd like there to be a focus on engagement at practice and PCN level with residents, and as I say, any other stakeholders who wish to be involved in the discussion. And that will be led by our primary care teams within each borough. The money for access, and this was additional money on top of the contracts general practice already has, is still available. And individual PCNs can come forward and ask to be involved in the access initiative, and that will trigger a payment to the practices. So the money is not lost. We have a commitment to learn as an ICS. We have to. We have to use all the strengths we have at the board level, be that members of the local authority, be that GPs, or be that highly trained managers. We all need to work together more constructively so this doesn't happen again. But lest we forget, we have a shrinking workforce. We have a rising level of demand. We have patients who want timely transactional access on the same day. We also have a growing population of patients with complicated care who need continuity of care. And sincerely, this initiative was an attempt to try and solve both of those two needs for our public. I hope we can discuss that as well as what went wrong. Thank you for your time.
Thank you very much, Dr. Bakaman. I note what you're saying in terms of the learning points, no? In terms of the engagement or the lack of engagement and the impact that it's had in terms of people's reaction to that and concerns.
Of course.
I actually took part in one of the Hammersmith events, and there were over 100 residents, patients, very concerned about what was going to be implemented, and the level of anxiety was quite concerning. I also heard the same concerns at the Joint Health Overview Scrutiny Committee, where we had representatives of residents' voices from across Northwest London. So I welcome the fact that it's an acknowledgement in terms of that engagement process and how it could be improved. Thank you for coming this evening. Do the other speakers wish to speak? Ms. Parkin?
I think we're happy if people have got, because I know that I've spoken at a number of events quite recently about exactly the same thing. So I think what we wanted to do for the purposes of this meeting was actually allow people to ask questions to try and assuage people's anxieties and to make sure that we're all actually moving forward collectively together, because I think that's what we're really keen on doing, if possible. So if people have got questions, and
thank you very much. So before we move on to questions, I would like to invite as well Dr. Kylie Kramer, who's joining us here this evening, and also Meryl Hammer on behalf of Hafson, on behalf of the residents' voice, basically. Who would like to start, please?
Thank you, everyone. Thank you for having me this evening. I'm Dr. Kyla Cranmer. I'm a GP at PAC Medical Centre. I've been a GP there for 11 years now. And I'm also the chair of the Hammersmith and Fulham LMC, which stands for Local Medical Committee. So I think I'd like to just raise a few points and possibly questions back to the ICB about the proposals. We've had an update today, as to where things stand, which has been helpful for us to see. As you know, the LMC raised a lot of initial concerns that related to things such as patient safety with regards to the level of clinicians doing the triage, the oversight of that, potential for loss of continuity of care and widening health inequalities. And there's no GP that's going to deny that access is a problem, not just in London, but across the country. And we know actually that access is a problem to all parts of the NHS at the moment. You wait for months or even years to see your outpatient appointment, your operation, your community health providers. Access is a problem everywhere. We also know that GPs are providing more appointments than ever before. And yet there's still a problem. And it seems that the main impetus that the ICB are telling us that has driven this change and driven this mandate is that it's because patients are telling us that this is a problem we have to solve. I'm interested to know from the ICB if we've asked patients if it's just access that they want, or is it also important for them to see a qualified doctor versus another clinician? And is it important for them to be seen at their own GP surgery versus another site? And so that's quite, if you ask people, do you want to see it, be seen on the same day? Of course, they're going to say yes to that, but there's much more to it than this when we break it down. The access proposal that we've got seems to come largely into sort of two parts. One aspect is of triaging, and another aspect is of sort of seeing patients with low acuity or more simple problems, perhaps at a different place to their own GP surgery. Now, our practice has been developing and trying to improve access to our patients for years now. We're constantly evolving, constantly trying to develop our model, constantly trying to make it better for patients. And that never changes. We're always trying new ideas, trying things out. And of course, after COVID, things changed hugely with the way that we do things. And so I see triage as a fundamental part of improving access to general practice. I absolutely do. What I disagree with is that it's done in this way at scale and that there's good evidence to do that. I've not seen that evidence. What we know, or what I believe, is that triage is a highly complex thing that we do in general practice. And for our site and for our PCN, it's GPs that do our triage. And we think the most senior GP should be doing the triage, should be sitting at the front door. So in my practice, I literally sit in reception with the receptionist triaging every call that comes through to make sure the patient gets seen by the right person. If a patient fills out a patches form, which is an electronic way of accessing us, again, a GP triages that. But what we know from our surgery trying to do things at scale, because we've tried things at scale, we've tried different models out, we've tried to make things better, is that everything ultimately comes back down to the site, and that the individual GP practice is the most important place where the patient needs to get their care. Because we know them, they know us, and we know the staff that we have in our building. Our staff has become incredibly complex now through the ARRS funding. So we have pharmacists, we have physios, we have social prescribers, we have all these wonderful people working for us, but they are all downstream of that triage point. And once the senior decision GP has decided where the patient goes and what happens, they then will see one of those ARRS staff. They do not sit at our front door deciding where the patient goes and where they're seen. If we take our ARRS staff away from that, what they're doing at the moment, to go and manage this access hub, then we will be, quite frankly, robbing Peter to pay Paul by taking them away from one part of the business into another. And we know our ARRS staff. I've got 3 pharmacists in my practice. They're all amazing, but even within that, they have subspecialties of brilliance that they do. So I can send my patients, go and see this person about your asthma, go and see this person about your diabetes. They all sit downstream of that triage. When I'm the triage doctor, that's a full day of calls, and it's a really hard day. And that's just for one practice. That's just for one site. It's a full-on day where I might deal with 50, 60 things, as James has described this morning. There's no way I could do that as a one GP across a hub, supervising all of these other staff managing that. It would be dangerous, frankly. I couldn't do it. I just about get through the day on my own practice with those patients that I know. And I have the benefit of working there for 11 years. So half of the patients that call in that day, I already know them, I already know their problems, I already know how to deal with them. So that makes my job a lot easier right from the get-go. The other fundamental part of this model that I really, really disagree with is this splitting off between same day easy care and chronic complex care, because we all know as GPs that what seems simple one day is complex the next, or it's become that over time. You don't know as a fit and healthy person the first time you see your GP with abdominal pain that actually that's the start of your cancer journey, and that will develop over time. Continuity of care, we know, is so important because we know it improves health outcomes, we know it improves patient satisfaction and GP satisfaction, which is important as well. And by splitting things up, we're already breaking up continuity of care. I really believe that our care has to be held within general practice. We are holistic practitioners. We are cradle to grave GPs. That's what we do. This splitting up of transactional same-day healthcare and chronic complex care, for me, having done general practice for 11 years, that's not what I see. That's not my day in, day out. Someone might come in with a simple toenail problem and I'll think, gosh, you've not had a blood test for 10 years. Can you go and have one on your way out? They'll see me next week with their new diagnosis of diabetes. That's what we do in general practice. That is not going to happen in the same day access hub. And so I think it's really important that we keep things at our own GP sites. And so I really, really do not want to see general practice split up this way. I also worry for the future GP trainees, because it's only by seeing 100 slightly unwell children that you can then spot a sick child. And that's a training process. And if all the slightly unwell children go off to a hub, you're not going to pick that up as a GP. It's only by seeing 500 slightly normal looking throats that you suddenly spot a slightly abnormal one and think, I think that might be a throat cancer, and hey ho, you've picked one up. You can't get that sort of training if everything's diverted one way and another. So I really think that we need to keep things at a local level. My concern with the current plan is it still demands that we do this at scale. So what's already working for our practice, we would have to stop and change to an at-scale business. Now, what's right for my practice and my PCN might not be right for another practice and another PCN, depending on their skill mix, their staff. Some people really struggle to recruit GPs. Every practice, every PCN is different, but they should be allowed to develop their own model for their own patients and what's right for them. It's still being mandated that it has to be done at scale. You say, James, practice by practice, this should be looked at. I totally agree. It should be practice by practice, not necessarily PCN by PCN, because that's not going to work for every PCN. I think the money is there and it's not mandated, it's optional. But of course, if a GP surgery or PCN decide that that's not the best way to care for their patients, then they're not going to have access to that money to improve their services. And I think that's a really important point. I also really, really worry about our vulnerable patients who already struggle to get access to us. And I think by having to jump through extra hoops, I've looked at the flow chart that I presume KPMG have given of how it might work. A patient calls up, they press 1 for same day access. They speak to a care coordinator, gets triaged to a clinician. The clinician's then got the GP overseeing this system, and then they'll decide, actually, that's complex, go back to your own site. It's about 5 steps that patient's gone through. Currently, if that patient called my practice, the receptionist would turn around to me and say, what shall I do with Mrs. So-and-so? And I'll say, stick them on the list, we'll see them this morning. I don't know why we're making it more complicated. We should be providing resources for the practices to make what we already do better. I think I'll leave it there. Thank you.
Thank you so much, Dr. Kramer, for your contribution, and also just giving us the detailed information from the experience that you have in your practice and the concerns that you're raising in terms of the challenges ahead with this potential model. Thank you. I would now like to invite.
Right. It might be helpful if I responded to the first bit, so we capture all of it, because there were several questions and points in there that I could respond to, and then obviously Meryl always has useful feedback, but could we just respond to each bit as it comes along? That just might make it more cohesive and comprehensible.
Okay, let's take that in it, and then I then invite questions as well from members of the PAC.
All right. I think the first thing to say is Kyla and I know each other for a long time, and I don't disagree with anything you say. And inside the ICS, there has been lobbying around these issues right from the off, and we have listened. So I just wanted to correct a couple of things. We are not insisting on access at scale. What we are asking is if PCNs and practices want to, they can engage in a conversation about the access they have at place with their patients that we will facilitate, and what evidence there is emerging from the 10 sites in Northwest London, but also internationally, as to what models could potentially, if they chose to, improve access. And the point about continuity of care, absolutely inherent in this, is about trying to improve continuity of care for patients who need it. That's a difficult concept, because I need to slay a few dragons here. We cannot offer continuity of care to everybody. You cannot see the same GP. It's just impossible because of the level of demand and the falling workforce. Another dragon to slay. Triage has been part of the NHS for decades. You call LAS now, your call will be triaged, not by a doctor. If you go to the front door of Charing Cross Hospital, Chelsea Westminster Hospital, you'll be seen by a nurse, and your care will be triaged. And a decision will be made without a doctor in the room, unless they think it's of a sufficient complexity to bring in a doctor. This already happens. It happens at 111. There are not doctors on the end of the phone of 111. There are allied healthcare professionals who are trained to triage. So the concept of triage is already embedded in the NHS. A couple of things I also like to say. We have tried for many years to improve access by recruiting more doctors, but as we couldn't get them, as Kyla has pointed out, ARRS professionals have come in. And if you go to practices now, you'll see that there is a doctor there, but there are physios, there are pharmacists, there are first contact HCAs, there are trainee nurses. There's a huge swathe of staff that have come in to try and help improve the contact the public has with the GP. But the idea that you can see the same GP when you want throughout your medical journey, I'm afraid is illusory. The last thing about vulnerable patients, I absolutely agree. We have a real problem with digital exclusion. We are seeing that with all manner of patients, and we have to address that. But as you know, one of the ways our group practice is trying to address that is by liberating certain doctors to work with a team of allied healthcare professionals to proactively work with patients who are vulnerable, be they frail, have dementia, learning difficulties in nursing homes, or confined to their own homes. Now, that's because we have innovated to do that. I would highlight that that's not the same across the patch. And one of the problems with this initiative that was shot down was that we were trying to implement it so that everybody did it. One of my concerns will be that absolutely it'll be an opt-in, it'll be a discussion. But if you're PCN, if you're registered with a PCN or a practice, that does not want to opt in, that does not want to have a discussion about how to improve access with their patients, they do not have to now. And so we will see inequity of access evolving over time, where you'll see the forward-thinking PCNs like ours engaging in the conversation, and others, and you'll see other PCNs that struggle for many reasons, they're not malevolent, falling behind. And I just think that's a regrettable repercussion of this.
Before I invite Meryl, I want to ask Dr. Kramer, have you got any initial thoughts on Dr. James?
Yeah, so at scale is not going to work for every PCN on this. I don't even think it works for my PCN on this, who is quite capable of working at scale, because I think patients need to come to their home practice. So are you saying, because you're saying that PCN should enter into a conversation about the model that they're going to propose, if they decide that their model to improve their access is not at scale, but is in their own practice, but amongst their PCN, does that mean they will get access to that money, or they'll be excluded for access to that money?
Okay, so to be clear, by calling it a QI process, exactly that. The position we're taking now is we simply want leaders within those practices and those PCNs to sit down and have a conversation with their patients, maybe with their local authority representatives, maybe with local faith groups, about what is happening with access on their patch, backed up with data from us, so you can have an evidence discussion, backed up with whatever international, national evidence there is about where places have improved access because the patient feedback is more positive, because the outcomes is more positive. And all we want people to do is honestly, openly look at that information. And if at the end of it, you say, everything we do is fine, not going to change a thing, thanks very much, you still get the money. I doubt patients, local authority, local groups are going to sit there and go, you know, we've had terrible access, and look at all this evidence, look at what you're doing, and there is a difference, but that's fine. This is about empowering all the stakeholders around this, not just having a conversation with GPs who have said no.
But if practices decide to use the money to improve access individually and not at scale through a hub, will that be okay?
Absolutely.
Thank you.
Yeah, just to reiterate that. So I think just going back to James's initial point, the purpose of us being here this evening and all the work that we're doing with our patient reference group is actually, you know, we know we got it wrong last time. We are saying exactly that. We are saying exactly that what we want to do now is that we work with residents and GPs and others to say, what is it that will be suitable for your particular patient population, ensuring that we don't increase any inequity, but it will vary. It varies now, but the purpose, I think, of moving forward, it's almost like we need to draw a line. I think we didn't do it very well. Where we've got to now has been, you know, in lots of ways not as good as we would have wanted it. What we now need to do is make sure we're doing exactly what we should have done at the beginning, is saying, look, this is a proposal. We know the access is really poor in certain areas. What can we do? So we get everybody's opinion, and then we make an informed choice for your particular practice and PCNs across the piece. So it's absolutely not written in stone. And I think that's really a key message for the purposes of this evening.
And just one last point, we're asking practices to simply ask their patients in an open forum, in a patient group maybe, which they are contractually obliged to have, how's access? Now, what's wrong with that?
Thank you very much. I would like to invite up Meryl, the patient's voice, please, Meryl.
Right, I'm probably a bit croaky and may have to resort to a puffer, but never mind. I also want to say that the paper that was circulated, presumably because the ICB didn't provide anything more recent, is a paper that was written for a meeting on the 14th of March, the JOSC meeting. That is largely what I have responded to, but I have also looked closely at a meeting that took place online on the 20th of March. It happened to be the same date that we had a very big AFSON meeting on the same topic, but I have looked at the video since, and indeed quote from it from Dr. Genevieve Small, and I have to say some of the things that have been said here tonight do not match up with Dr. Genevieve Small's comments at that meeting. So I think, and this is preparatory to what I'm saying, what I am responding to, I regard as the official line from the ICB, and I think it's important on that basis that the ICB gets its public lines straight so that we know exactly what is being said or promised, because what you're saying tonight is not what was said on the evening of the 20th of March, and that is hugely important.
And
But
Meryl,
let
that's why we're here. We're here to
No,
straighten out the
it
narrative.
wasn't in writing and it wasn't circulated in advance. So I am responding to what I see as the official line, and it must be in writing. It can't be just something verbal. We've heard apologies before. Apologies are simply not good enough. Let me go on with what I've actually prepared for the meeting. Hafson has emailed many thousands of people on same-day access. It has held street stalls in Hammersmith and Fulham. It has held a number of unusually large Zoom meetings where people, including medical staff, were enabled not just to ask questions within 1 minute, but express their views and discuss these in depth. There are about 15,000 signatures on petitions and growing. A personal story. You can hear what this is about. In the last 9 days, I have had cause to contact my GP practice twice. I have had appointments on the same day, each time, not by phoning at 8 a.m., but by completing a patches form somewhat later in the morning. These were triaged by a senior GP in the practice, not the same practice, but the same mode. She arranged for me to be contacted by a paramedic, so we're not opposed to that notion. One of the additional role staff to arrange a same-day appointment. Later, the same doctor arranged for me to have an appointment with her as the treatment was not working as quickly as expected, and perhaps I needed a change of prescription. All smooth sailing, as for so many patients. So, no phone rush at 8 a.m. And in this practice, the new cloud telephony, which the ICB tries to say is a wonderful new invention, and it is, for those who don't have IT access, means that patients can be called back with the receptionist assisting in completing a patches form with the patient. There are some vitally important points to note here. First, no hubs. The contacts and the triaging are all done in-house in a practice where the patient is known and knows the practice. That's continuity of care. Second, triage. This is done by a senior GP at the practice. Third, cloud telephony and the improvement in online access apps have had a significant impact on how patients can access their GPs. Yet this has not been taken into account by the ICB in its proposals. It is clear from just this one example that there is much excellent practice in Northwest London, which is seriously at risk of being destabilised by these current proposals. The ICB claims that it has been poor communications that have caused the anger, and I think it's anger, not worry, the anger, etc., and apologises, and we've heard more apologies tonight. Indeed, poor comms. I wonder why. That is not the core problem. It's the proposals themselves. A poor product is not improved by good advertising. The ICB starts by defining the problem as one of primary care access. And in broad terms, most of us would acknowledge that this is very possibly an issue. But to jump from this to a conclusion that it is same-day access that is the problem is a big and, at the moment, unsubstantiated jump. Where is the data? Much of the ICB paper is full of unsubstantiated assumptions. The ICB have called in KPMG, an accountancy consultancy company not known for health expertise, to present to GPs ideas that come from across the country and the world. ideas that have nothing to do with the populations of northwest London. Why have the ICB not simply gone to local GPs and asked, what are their access issues in general? What do their patients mean by GP access difficulties? How do GPs manage access? Are there particular issues around same-day access? And then address those issues and set up support systems for those practices. Why the sledgehammer to crack what might well be a small nut? And where is the data on the pilots, which we are now told are early adopters? Let's not ask what the difference is. We have no published account of whatever they are. No independent evaluations, and we are now told it's too early. Yet the ICB is pushing for these plans to be rolled out before such evaluations are made. And now it seems PCNs and practices can come up with their own ideas, but only within the ICB framework. And as my own GP said, they still have not been told any more than that the 1st of April deadline no longer applies. That may be out of date, that was yesterday. Hubs. To quote Genevieve Small, when we say hubs, that's not really a physical hub. We don't have that much estate in northwest London anyway. But what it will be is a virtual hub where triage will take place. As for triage, Dr. Small says, when it comes to triage, it is really important that it is someone who is a senior clinician. So that is likely to be a GP. It could potentially be one of our extremely well qualified nurse practitioners, advanced care practitioners, because they really need to be extremely well qualified. But anybody who is not a GP will always be well supervised by a GP. Only the most naive of patients would put their trust in such a list. All this begs multiple questions. Any initial triage at a virtual hub will be by the person who answers the phone, presumably the care coordinator, who is not a senior clinician, but who will be referring the patient on to someone else who may not be a senior clinician. And for all of the staff referred to by Dr. Small, how on earth is this supervision to take place when the hub is virtual? At no point are these issues clarified, and they are issues that are core to patient safety. We fear that there will be more Emily Chestertons. Where, and it hasn't been mentioned tonight, where is the Equalities Health Impact Assessment for this radical change? We were told at an ICP meeting that it would follow after implementation. Too late, I would suggest, since once it is in operation, it will be difficult to change. Yet accessing GPs, same day or otherwise, and the mode of access is a core part of NHS provision for people, not least for those who are poorer, older, from BAME backgrounds, and those with certain disabilities, etc. Finally, the fullest stocktake, much cited as justification, simply does not support these proposals in the way suggested. A couple of quotations. We heard consistently throughout our engagement that a top-down approach to driving change and improvements risks alienating the workforce and communities. Page 6. And it's going to require pivoting away from top-down directives and creating an environment that supports local change, not dictates from the centre. The damage has been done. A lot of work needs to be done to undo the damage. Access to GPs is important. Whatever that access is, too important to be treated in this way by the ICB. Thank you, Natalia, for inviting me to speak this evening.
Thank you very much, Meryl. I appreciate your time today and representing the voices of the patients, of the residents that have come to you with all the concerns that you've put together in your presentation. I note references to the anger that there is from the patients as well, and concerns about safety and also the quality impact assessment. Some serious areas of concern there. I'm keen to hear from Dr. James, please.
Yes, thank you, Meryl. You always positively contribute to these conversations. I'm really glad that you've had good access to medical care and that you're on the road to recovery. Obviously, your practice is dedicating a lot of resource to same-day access to facilitate your triage and access to care, which is great. Unfortunately, we can't go on an N=1 sample. We have to go on what the surveys of public in North West London feed back to the ICS. And what they consistently feed back to us is a sense, whether it's a reality, different at different places, but a sense that they cannot get access to a GP. Backing up that data, 40% of children under the age of 15 in this country have accessed private general practice services, mostly Babylon. One of my big concerns is while we let this narrative run, that you can't see your GP, even if you get access to a general practice on the end of the phone, you're not going to speak to a doctor. Generations of people are learning that they don't go to their GP for medical care, they go privately. And if we break that link between a tax-funded, free at the point of access healthcare system with young people, the NHS is in existential crisis. So I'm glad you've had good care, and I'm glad you've had good access. But when we speak to the public, that is not the story they hear back from us. Okay.
Sorry,
Let me just respond to your point. Let me just finish my point. We are not any longer insisting on at-scale hubs. We are asking for a conversation at place with residents, with patients, between the GP practices and the people they serve about access. Because if a practice is offering excellent access and the patients say it's fine, we don't want anything to change, then nothing will change. But we would like them to have that conversation. And I do have to point out that throughout my career, I have worked with highly professional, highly skilled nurses, physios, pharmacists. They run oncological services, they run dermatology services, they run services in mental health in the community. And I think stating that a patient would be ill-advised to see those healthcare professionals to handle their care is scaremongering, and it shouldn't be allowed.
Can I just come back? I know there are other people that want to speak. First of all, you've talked about data. That data, and that's part of my point, has not been presented about the access issues. You can't just say to us there is data and not present that data. If there is that data and that data applies to North West London, then provide it to people in North West London and show that data in some detail. When the public are not fools, but we want to see the data. Instead, you've said, I reckon that 99% of the people in North West London wouldn't know how to approach the ICB because they come to us and ask questions about how can I speak to someone. So that data has not been shown, and to say that there is that data in that blind fashion is quite deceptive. The other point is that nothing I said spoke against using ARRS staff in an appropriate fashion. In fact, I spoke about being referred to a paramedic, and I made no critical comment about that. Thank you.
So just quickly to respond, if you read the newspapers today, you'd have seen that satisfaction with the NHS is at an all-time low. We can get the patient feedback about access for North West London and nationally, and we will supply that in the conversations about access. Because one of the problems we have when challenging current points of view about access at place is everybody has a firmly held belief. And unless we can agree on a clear truth about access and how we use the resource to facilitate it, these conversations will go round and round in circles.
Just to follow up on this point, is there data from the pilots that have been carried out that could be shared with members of the PAC team?
So we certainly are collecting data about the impact of the pilots around access to care, patient satisfaction, and outcomes for the patients, as well as staff satisfaction who are facilitating these sites. Clearly, we do not have that in a presentable form yet. We don't have, it hasn't been running long enough. And one of the internal criticisms has always been, we do need to have data to back up how it lands in North West London. We have data about other sites in other parts of England and internationally that have used single point of access at scale hubs. But we will collect data about how it lands in the population in North West London. Clearly, we got ahead of ourselves. We don't have that data yet, but when we do, it will be presented and it will be discussed honestly.
And I hear your point, but of course, if there are concerns raised about access, but at this stage we don't have that data, I mean, I think it's important to show that data.
So just to come back, and then our friend here would like to come in. I think we can look at North West London data. We can look at the site data. We can look at national data. What I would like to encourage is a conversation at practice level with the people that those GPs serve. And if the conversation says, you know, our access is fantastic, don't change a thing, there is no impetus on the GP practices to change a thing. And we will fund them to have that conversation. That's all.
Thank you. Jim, on this point, because I know Councillor Horace.
It's on several points, actually. First of all, let me make a suggestion to James. I've got full respect for GPs. I'm alive thanks to a perceptive GP who saw me a few years ago about something which I thought was trivial. Within a minute, he worked out it was serious and sent me to Charing Cross. He saw me, he made a judgment on his skill. He was not an auxiliary for whom I've got full respect. I worked in education with auxiliaries all the time, managed them, but they did not make the key decisions. They were made by people like me, fully trained, just like my doctor. So I think the term scaremongering, it isn't coming from people at this level. I've got several things to say. One is what's being said by James and the team this evening is entirely at variance. Now, let me underline that, entirely at variance with what was said by the ICB at the JOSC meeting, reviewed on screen afterwards, at the meeting last week online, which I didn't attend, but I've looked at it online. What you're saying, James, is quite different. It goes in the opposite direction. And on the question, there are quite important things. If there are evidence of the pilots, we were told by Dr. Small, there are not pilots. She said it several times when a Conservative councillor asked her for the evidence. She said, she used a different phrase. She said, we haven't got evidence. What we've got is anecdote. There's quite a distinction between an anecdote and evidence. This goes back to one of the two nubs. One of the nubs is this: we were misunderstood. The trouble is, the papers were read in detail by some of the most skilled medical journalists in the country. I defy you to get into a conversation with Eliza Parr from Pulse and people like that and say, you can't read. They read all of the papers. They got it right because we get sacked if they didn't get it right. The people we work with, my job depended on reading complex papers from the Department of Education and Science and getting it right, else I'd have been at the door. So if things went wrong, it went wrong at the far end. I think blaming comms is wrong. I've never seen something like this before. Look, the comms people are good people. They're skilled. They know what they're talking about. They do what they're told by people who are not comms people. Look, this didn't go to patients, didn't go to GPs, didn't go to council reps, didn't go to MPs, it didn't go to anybody. In the past, they've always gone there. It looks to everybody as if somebody, not you, James, it's somebody up in Marlborough Road, tried to put something over on people to advance it so far, it could not be stopped, queried, it couldn't be nuanced. And at this stage, there's been a public car crash of a kind which hasn't happened for years in the NHS. It even covers today, I notice again, in Pulse, in the BMJ, etc. So it's an unexampled kind of car crash. Not poor comms, a bad mistake. Now, let's get back to part of the nub. Part of the key advance was to be that people who want to contact on the day would get in touch with a hub, not with their practice. You'd be put through. We were told there was evidence, told repeatedly, that people found frustration with access, fair enough, but suddenly access became on-the-day access, repeatedly. No figures were given. Repeatedly, people have asked for publication of figures. They've not been given. But in the real world, if you have figures and they're good, you give them. So my reading is quite simple. If no figures on anything be given, it's because the figures actually are either complex or not available or don't exist. The policy was thought up before the evidence, just like shaping out the future to close Charing Cross hospital beds and to close Ealing hospital beds. When evidence was asked for, it never came. Let me underline the word never, because people asked in very senior research positions for the evidence. It was put off. We'll get back to you. It never came. There's been no apology, by the way, when Matt Hancock pulls the closure, because presumably he saw there was no evidence, and I'm not part of Matt Hancock's party or any party, but the people who said it was safe didn't have it. Now, look from a patient point of view. I'm not a doctor. I have no training. I'm not even an auxiliary. But when I saw a doctor and he recognized something, then I recognized something. It was this. One of the key things about my practice, which I rarely see, I've been healthy for most of my life, is I trust the practice, not just the doctor. Let me give you an analogy. When I worked in education, I've worked in this borough. Very often students, adolescent students, would see somebody. They see somebody privately, they trusted them, they would not talk on the phone about quite intimate things, sometimes life-threatening things, often from unfavored backgrounds in the poor parts of this borough. They would trust the institution they knew well, which was the private part of the school psychology service, and the school doctor. They would not have rung up and talked about intimate things to somebody in a hub. I'm all for hubs. I'm all for telephone conversations, but the key person that you need to know you can see, if you need to see, needs to be a trained GP. Not on the day necessarily, not in a week necessarily, but you need to know if you need somebody and you decide, you can see that man or woman. People like yourself, James. That's the important thing. Continuity of care does not mean the same person day, week in, week out. It means an institution that you know will look after you, that when you go into the waiting room of my surgery or yours, that you recognize the place there, a conversation will start, which starts with you, but it may turn into a conversation about your mother, your family, vaccinations, measles, or whatever. That's what happens. But it will not happen if there's a primacy of the hub. And what we're still left with is the primacy of the hub. We want that in writing. It's been withdrawn. Once it's been withdrawn, conversations start on a realistic basis. So what you're saying,
Thank you.
write
Thank you,
it,
Jim.
please, give it to us, please, and then a conversation will start on a realist basis.
Thank you, Jim. Dr. James, do you want to respond to on the comments, questions I have made?
As always, Jim, very concise and eloquent. You did listen. Things have changed rapidly, and I think will continue to change as we continue to listen. And I think over the next year, one of the things we have to do as an ICS, don't forget that includes all of us, we're all in the ICS, is demonstrate to the public that we are listening. And as much as listening to, we don't want a hub, we want to see our own doctor, we also have to listen to, I can't see a doctor, I can't get access when I want it, I'm going to call 111, or I'm going to go to any, or I'm going to go privately online. We have to listen to all of those voices. And what we now would like to do is, yes, apologize for the mistakes that have been made, but move forward and have a conversation with the residents, with the practices at a level of place, so local authorities, local organizations can be involved in that conversation about how we solve this knotty problem.
Could I ask you a question, James? Because what you said really is interesting.
James, sorry, James.
Could I ask James? Because James asked questions.
One question, please, because I've got Councillor Harris as
Just
well.
a simple thing which Councillor Harris may. Do I take it from what you're saying, James, which I welcome, that the proposal as it stands initially published has been withdrawn?
The proposal that went forward at the beginning of this discussion about access, that went out to the practices and was attached to the single offer, has been withdrawn. We are now putting forward to the practices an offer, an opt-in offer, to be involved in a conversation at place about access. And in that conversation, we will put forward evidence about what has improved access nationally, internationally, and I hope we will have useful data or information coming from the pilot sites in Northwest London.
Thank you for the update. Councillor Lloyd Harris, please.
Thank you. Hey, a lot of the questions have been asked, but I'd have to say that it's not often that Meryl and I agree probably nearly 100% of what's been said, but I think she's asked some very relevant questions that do need answers. I'm more than slightly concerned. Dr. Kavanagh, you said the NHS is an existential crisis. I would have to say that the reason for that is this proposal. It's been badly thought out. It's been presented in such a way that you're not going to take people along with you. And with all due respect to yourself and others, there's a sense of, it's rather patronising. There's a sense of you will agree to it because we are who we are, because you haven't provided evidence. Where's the data? And I tend to agree that if you don't provide data, and we've had other examples in the council of this, if you don't provide data, people then question, why are you proposing this? There's got to be some evidence to support what you're proposing. If there isn't, then, like we've done previously with this PAC, we've suggested that actually the business plan be returned until there's some actual evidence provided. And this, I don't think, stacks up. So I can see why there are a lot of people that are upset about this, and it's created anxiety and fear. My concern is, given that the people involved are all medically trained, how did not somebody think that patients would be anxious over these sorts of changes? That to me is fundamental. Somebody has fallen down on a job and not listened or anticipated. And that is not what one expects from medical professionals. So that aside, because I've got, you might want to answer, some of them you won't need to answer because they're just comments. And I think the comment that was made about the vulnerable patient, the potentially going through 4 or 5 different sort of layers of being triaged on. Now, I'm a psychotherapist. You are going to lose patients. People that need instant answers, they need to be listened to, which doesn't seem to be happening at all here. So you are going to lose those. And there are some very, very vulnerable people in our community, and we need to shorten the process so that they are heard and, you know, directed in the appropriate place. So that, I think, is sort of paramount. You've also said that this is sort of an opt-in proposal. I'm just wondering, over a period of time where there's going to be pressure put on maybe those practices that choose not to opt in, because at the moment there's not sufficient information as to why you would. So I'm just wondering what your plans are potentially for those that choose not to opt in, and what impact that will have on service provision for them. Because we just can't keep going around from practice to practice. And I'd have to say, in the last 3 weeks, I have lost so much confidence in my GP practice. It's appalling. And mentioned to Deborah which one it was at the last meeting, and it shouldn't go on. So what do we do in that regard to those practices that don't have these panels or patients that talk and engage with medical staff? What happens to them? Because those potentially, we're not going to know what their thoughts are as to whether they think this is a good idea or not. And if we don't have the practices on board, we don't have the patients on board, then you'd have to question, why is this a proposal? So I think that's probably about it. But I think if you can potentially go away and come back with some facts and figures that stack up, and I know it probably sounds patronising, but I've got a family full of medical specialists in 3 continents. So it comes from a position of wanting this to work, but I don't see at the moment what's proposed is workable in this form. Thank you.
Okay, could I respond? Okay, so on your first point about the theoretical existential threat to the NHS, I'll just repeat the point I made. There is a sizable proportion of people under the age of 15 in this country who have accessed care, medical care, privately. And the risk to us all is if that thread that runs taxation system, funding a healthcare system that's free at the point of delivery, if a generation of people come through and think, well, when I'm sick, I just pay, I've got medical insurance at work, I'll go through the private sector. We have a limited workforce in this country. As the private sector grows, more and more people will go across and work in the private sector. People not thinking their point of access to the NHS is a GP, an NHS GP, people training as doctors in this country and nurses and physios and psychotherapists thinking there isn't really a well-paid future for me in the NHS, I'll go and work in the private sector, which is burgeoning. That is the direction of travel which presents an existential threat to the NHS. And I am sincerely worried that when I get to the point when I need care, I will struggle to get good NHS care if that continues. So that was a point. Indeed. Okay. On the point of vulnerable patients, I'm proud of the fact that in North West London, we have put several contracts out to GPs across North West London so that they proactively reach out to groups of vulnerable patients, be they frail, be they have mental health issues, be they people with complicated diabetes. And we pay GPs on top of their national contract to proactively reach out to those groups, people with learning difficulties. We cannot cover all bases, but we've tried very hard to engage those patients who do struggle, but they will continue to struggle to have access. And we need to speak with them and work out how we can improve it, but we are trying. Your question about what happens to practices that do not opt in. Currently, most of the contracts that GPs have are based on trust. It's up to the GPs whether they open their doors and they have access that is equitable and excellent, as you have. But I'm sure in North West London, there are practices that sometimes don't open their doors, and we send people around to inspect them. And if they don't, we issue a contract breach on them. And there are practices all over North West London that have contract breaches on them. And my colleague from the LMC may want to discuss what the LMC feels about practices that have contract breaches and how best to support them so they come back in line with what we think is good practice, because the LMC does a lot of that work. But because of the furore of imposing, we've learned from that. And so it is an opt-in. If we turn around and say, we have to do it, we're going to get brickbacks again. So we're back in a position where forward-thinking, first-moving practices will come forward and say, we do want to be involved in a conversation about access. We'll take the money and use that to facilitate conversations with our patient groups. And if practices do not have patient groups, they are breaching their contract, and they would have a contract breach notice served on them. And we do that.
Thank you. Councillor Coleman.
Yeah, thank you very much. I don't intend to make a long statement, but I would like to ask a number of questions. So if you'd assume that I ask a number of questions and haven't made a long statement, that will perhaps be the same thing. I'd like to talk about a little bit about evidence, a bit more, and about where we're going from here in terms of actual consultation, because I'm not quite clear. But first, before I do that, can I just clarify? I misunderstood you, James. You said we're putting in, as it's picked up by Councillor Lloyd Harris a little bit, we're giving GPs an opt-in, we're putting together a GPs an opt-in offer about being involved in a conversation about access at place. I want to understand, Are you intending to consult with every GP about access at place now, every GP, or do they have to make some sort of opt-in commitment first? Because I wasn't quite clear.
So we're offering to practices and as a group, PCNs, a sum of money to have a conversation about access at place with their residents and with other stakeholders.
When you say you're offering the money, what does that mean?
So there's a sum of money that will be given to practices if they engage in the quality improvement work around access in North
So
West
you've
London.
set out, but what I'm concerned about, what I don't understand is you've set out a way that you think is right. A lot of people think it isn't right. Are you saying that you're going to give practices money to engage on a discussion of what you've already put forward?
No.
What is it money for? A discussion about what? Are you going to enable people to actually have a much starting from a different point discussion and not taking the KPMG idea that you've been putting forward? Debbie, did you want to come in on that?
Yeah, can I jump in there? Just, sorry, James.
Sure.
Genuinely, I think we're all saying the same thing now. I think we're all saying the same thing. I think it has been not well thought through. I think, and I don't want to apologise anymore because I'm sure apologies are getting sort of slightly trite, but in truth, we are all saying the same thing. It has not worked. It's not the right thing to do. And we want to now draw a line under it and say, okay, what do we in North West London want? What do our patients want? And what do our GPs want? So it's not being led by the ICB.
In doing that, okay, this sounds very positive, but I'm really going to drill down on this. Forgive me, because I think it's the thing that I do not understand still. And I think there's some absolutely fundamental points which we have to make crystal clear so that assumptions aren't made, backs aren't raised, and we can move forward in a way which is constructive. So are you saying that we will now start again? Or is it that people will be able to consult with stakeholders and others on the basis of the proposals you've put forward? Or are we going to go back even as far as assessing whether there's a problem? And I say that because the papers that was given to the Informal Integrated Care Partnership 2 weeks ago, James, I was listening to what you said about your 52 people that you see a day, and you used to see very few. But I'm looking at the data that we were given on the Integrated Care Partnership, all the councils. In October 2018, there were 800,000 general practice surgery appointments by appointment type. In June 2023, there are 800,000 appointments. It goes up and down, it's gone up and down, but that's the figure which we were given. Those are face-to-face appointments. The number of telephone appointments has gone up over those 5 years from 100,000 to 400,000. But the actual number of GP appointments, according to the data that we were given by the North West London ICS, hasn't gone up. It's gone like that, but it's 5 years it stayed the same. General practice surgery appointments by healthcare professionals between 2018 to 23, they say 600,000 in 2018, 600,000 now. And it's much, the line isn't as extreme, the lines aren't as extreme, they're more like that. So there doesn't seem to have been an increase. The other practice staff are seeing more people, about 200,000 more than they were 5 years ago. But I'm not doubting your own experience. I'm just saying, I couldn't tell your own experience.
May I respond to that?
I haven't quite finished the question. I'm not doubting your own experience. I'm simply saying we need proper evidence that there is a problem. And I'm saying it because I'm in Hammersmith and Fulham, here in Hammersmith and Fulham. And so, and we mustn't be led also by the fact that there's a problem across the ICS. If there wasn't a problem in Hammersmith and Fulham, I don't think we want a sledgehammer to crack enough. And I'm a little bit concerned that there may be problems in other places, which we in Hammersmith and Fulham are having to deal in the context of the ICS. But my question, therefore, is, are we actually now going to go out there, talk to every practice in Hammersmith and Fulham about how quickly they can see patients who want to be seen on the same day, and what they have in place, and identify where the gaps are? Because that would have that's the usual thing. You say normal strategy development is, where are we now? Where do we want to be? How are we going to get there? Well, we know where we want to be. We want everyone who needs it to have same day access. But where we are now, there isn't a lot of evidence for that. So Debbie, is this money going to be spent just on consulting on ideas, or are we going to actually look at some evidence gathering first?
So there is evidence. we do have evidence of the amount of appointments we have and the amount of take up that patients consume, and the amount of appointments we either have DNAs on, do not attend, or actually
you have a point. You have data on how many people need to be seen on the same day, want to be seen the same day, and aren't seen on the same day.
Yes.
You do.
So we have all that data.
So what does that show for Hammersmith and Fulham?
So, and I haven't got that data in front of me.
What does it show overall?
So I would go on. So we have got data which we can provide you with. That is not the issue. The issue is what the perception of public is. So Meryl and Jim come every 2 months to our patient reference group, and without hesitation, the overarching for those 2 hours, and Amanda came last week, that for those 2 hours, are patients going, I can't get to see my doctor, or I'm not happy with the mode in which I need to access my doctor, which is exactly. But so somebody like Meryl, who you said earlier about patches, for every Meryl who goes, that was fantastic, there will be another 10 that go, it's the worst thing ever, I hate it. So what I'm saying is we have data, and we have not used that data. If from a personal point of view, I do not think we've used that data correctly to identify whether or not we have got a problem. And that is what we now need to do in order. We've drawn the line, we've drawn the red line of, we made a mistake before. Now let's look at what we've got, what patients want, what GPs want, because GPs and patients in relation to this are on exactly the same page. And the people around this table are probably on exactly the same page in relation to wanting to have the what do we need? What is the question that we are trying to answer? And the KPMG work, her line has been drawn under that. So I think let's not conflate the two.
You're saying absolutely, you're saying what you're saying is music to my ears, or music to everyone's ears. Are you prepared? Then just, I have to be sorry for going around the same like a circle and making a stuck record on this. Are you saying that the proposal put forward is being put to one side and we're going to start again? James, is that your understanding?
That is my understanding, but I just need to correct something. You're absolutely right. GPs have busted a gut to recover the face-to-face position from pre-COVID to now. But on top of that, we have emails, online consultations, patches. In Northwest London, GPs have 1.4 million patient contacts a month. They may have 800,000 face-to-face, but they have another 600,000 from other routes. So what we did during COVID is open up other routes of access, and then we were asked to return back to the face-to-face, and we didn't close off the other routes of access. That is one of the reasons why the system feels overwhelmed.
The data that I've got in front of me says when it comes to video and online, telephone, you look face-to-face, home visit, telephone, video online, or unknown. And there has been overall no increase in face-to-face. It's been up and down because of COVID. Home visits stayed the same, zilch to zilch. Telephone has gone up from 100 to 300,000. Video online stayed the same virtually. And unknown, don't know what that means.
I don't think the home visiting number is zilch.
Well,
with respect, I did 2 home visits on the way home today.
The home visiting
Maybe
number,
my colleague would like to talk about how
the home visiting number is between. Okay, the home visiting number is negligible. This home visiting number is the same as it was. Shall I say? If it was, it's on the north.
But the same isn't zilch.
You know what? James. Let me put it differently. Then it's on the north.
Please do, because I work with colleagues who break their backs doing home visits every day of the week, and to insist that they do zilch is an insult.
I'm explaining to you what I was in a meeting where you presented some slides to me, and the slide that you presented, you collectively presented to me, says naught for home visits to naught now. Now, I appreciate this because it's difficult to show the gradation between naught and 100,000 when you've only got a centimetre in which to do that. So there would have been home visits, but the point I'm making, which is a more substantial point, is it's the same number of home visits in 2018, October 18, as it is now, according to the graph and the data I've been shown, which is the only data I can go on. And it says naught here, but I appreciate if there are some home visits and it doesn't show up on a gradation of naught to 100,000, appropriately fine. But my point is,
I just wouldn't want the public listening today to think that the GPs in North West London don't do home visits.
Okay, fine.
And we can argue about the data and use up the time, but I don't
thank you for making that point. But thank you for making that point. That is really an important point, given the context of everything we're discussing. Can I go back to the main point? Are you dropping the proposals you have made for now and starting again with the residents and the patients? And I'm still not clear on that.
So there's 2 processes. For the next 12 months, of the at the PCN level will have those discussions and obviously can opt in if they want to and review what their own data.
Opt into what then, Al?
So as in they can agree to be part of the quality improvement discussions at the practice level around access, which is what we've been talking about.
Are those discussions? Well, I'm sorry to.
Yeah. So just to say, at the same
discussions?
time, there is discussions with interested GPs and the LMC that is starting next month around starting that discussion around okay, so taking the experience, taking the data and learning as we go from including the early adopter pilot sites, which whatever we want to call them, to actually start to look at what does the future look like so that we can start now and we start it together. So we're starting again, just as we've said, and we're going to have those discussions collectively. And as we go through and we engage at the practice level and at the patient level, and incorporate that into what next year or the year after looks like when we're in a position that we have the data and we have that position.
So you seem to be talking. That's helpful. Thank you.
So there's
clarify,
two things
there's
that
two
are
things
happening
going on.
parallel.
That's what I hadn't got it. So there's two. That's a helpful clarification. Can I just clarify what those two things are? One of them is GPs who want to talk about the existing proposal on the table, and the other is GPs who everybody who wants to talk about starting again. And if that's the case, how can they really run in parallel? Because they're two different things.
It's a journey. And so it's about learning from what we're doing so far and continuing that learning over the year.
Right. Yeah, sorry. Are you planning to run two different conversations? Are you hoping that the popularity of one will become so great that it will swamp the other? But if you're going to have two where people are going to buy into the KPMG idea, and what are the two? Sorry, let's clarify. What are the two parallel conversations more about? Perhaps we could be clearer.
So it's my understanding there are not two parallel conversations. Let's shoot that hare before it starts running around the field. There is a conversation at place with GP practices, with their patient groups, and with any other interested parties that have a stakeholding in access, including the local authority actually at place. It's very important. That is my understanding. And we will use, if GP practices want to opt in, there will be a payment because it's additional time that we're asking these GPs to put forward to be engaged in that conversation. Opt into having a conversation about the access at place that their practice serves. If at the end of that conversation, the patients, the GPs, other stakeholders say there is no problem with access here, we don't need to adopt any sort of process. There is no obligation to adopt any sort of process.
When you're giving them funding, you're paying the GPs to spend extra time talking about how to improve access.
That is my understanding.
And you think the GPs wouldn't want to discuss improving access unless they were given the extra money to do that?
I think most GPs currently work extraordinarily long hours. And if I went to them and said, would you join me in a conversation about access with your patients, with the local authority? I think you would get some, but I don't think you get as many as if you offer them money to be engaged in that conversation.
And what's the separate conversation then going to be taking, or the other, not parallel? What's the other? Well, it was Linnell, I think, who used the phrase.
Don't know of a separate conversation.
Can I try and clarify? Because it seems to be going around. How's it? So I think all the practices now have had a letter saying what was on the table is now you're not obliged to do that. So that's gone to all practices. So there is not an expectation that we have to have hubs. There's not an expectation that we have to work at scale. There is an expectation that within 24-25, we will utilise both GP's time and with our residents and local authority and wider providers as well to actually have a conversation about what might we do if there is a problem with access in your area and what might that look like. And if it transpires that across our 5 PCNs, they all want to do exactly the same thing and they all want to work at scale, then, you know, happy days. If they don't, there is not an obligation that they have to do it in that way. So I think that's really key. So you asked the question, Councillor Coleman, about whether or not that proposal had been torn up. And I would say my answer to that is that the proposal as outlined has been torn up. The idea around working at scale has not, and it may be that it's suitable. And in certain areas, and probably James and Kyla's PCN is a good example, where actually they have the capability of working at scale. The key thing, and I promised it last week at the PRG, and I'm promising it here today, is that actually we have the right people around the table to have that discussion for then what you end up with in April 25 being what you want for the services.
Right. Final question, and I'll shut up. What do you mean by working at scale?
I mean, if you want a hub, have a hub. If that's what your residents say that they want, and it may be, so I know we're all vehemently against it as it stands at the moment, it may be, we know it works elsewhere. You may look at it, we may look at the evidence, and people may go, actually, you know what, Debbie, that's a really good idea. Let's have that here. And that will be for us to have that conversation. What I'm saying is, so that's what I mean at scale, but it's not about patients having to go somewhere else in a different bit of the borough to actually be seen if they're not as chronically ill as the next person, if it's a one-off deal. What I am saying is it stands at the moment, we have the potential now, we've learned, we're not going to do it like this again, and we're going to take it forward with GPs and residents to make sure that what we've got to improve access, if there is an issue with access, and you know, you're right to call us out on that. We may not have an issue. And I think, you know, that some of us on this side of the table might be saying, actually, there doesn't seem to be an issue, but actually our patients are telling us that there is. And that issue is often not about whether or not they can get access, but they don't like the mode of access that they're getting. So they're the things that we need to discuss. So we're all on the same page, drawing a red line. Let's now move it forward, because I don't think we're saying separate things.
In relation to this, I have a question, please. So how is that evidence captured? Do all the practices have the same system in place, or are there different systems?
Yes, no, they all have the same. So
Is there
we have a platform. There's a platform that people can digitally access. We've got cloud telephony. What we do know is that some of the practices are more go ahead in some of those areas. We're trying to benchmark and make sure that everybody's got as a minimum a certain level of callback facility for appointments, and everybody's got a digital platform. We do, however, know that in certain parts of the boroughs, lots of the patients don't like that. And I may get Meryl and Jim to say that just from a PRG point of view, because we get that all the time. I don't like it, I do like it. So,
and what's the platform? What's a digital platform?
In order that, so patches where you might be able to, yes, or whatever platform that, and they do vary across London.
And then that feeds into a.
Yeah, so we've got all of the, so every practice will have on their appointment system, we will know how many patients has contacted their practice today in this particular form. And we know
how many calls have we missed?
Yeah, whether we've missed that, how long they've been taken to be answered, whether or not there's, you know, we've utilised a callback system, whether people then have had appointments and then don't turn up for their appointments. All of those things, we have all of that. We've got all of that. But what we haven't got is a consistent usage. And why would you? We would all be different, and we all access healthcare and everything else, the same as we would access social care differently. But our abilities as a population vary. So therefore, what we need to do as the NHS is make sure that whatever that patient needs in order to access that healthcare service that they require is appropriate for their needs. And that is what we have singularly failed to do with this proposal. What we want to do now is get it right.
Okay, thank you. Meryl,
I'll try and be quick. I think Debbie has clarified some of the issues, and for that, Debbie, I thank you. And I think, Debbie, what you have indicated is a working togetherness, because I'm afraid some of the other things I heard were a them and us situation. We're offering this, we're doing that. And that's where things went wrong initially. It needs to be working, the ICB officers working with GPs and from the outset with patients. It's interesting that PPGs have only vaguely come in at certain points on this. And James, if it's any reassurance, I can assure you our PPG is in the process of organising the next PPG meeting to discuss not same-day access, but access. It's already on its way out on an agenda at our initiative, not the ICB's initiative. And that is what is needed. But one of the things that I'm deeply concerned about still from tonight, although what Debbie's saying is also reassuring, is that only a few days ago, on the 20th of March, that is not the message that was being put out in a meeting for residents of North West London, and that is still on the website. That is not appropriate if that approach has changed, and it needs to be removed immediately. Furthermore, information needs to go up on that website, removing all references, if it's the case that it's been withdrawn, removing all references to the original proposals, and something needs to go up explaining that those proposals have been withdrawn and indicating what the new proposals are or might be. I think that's really important, but I also think it's important that these new proposals are drawn up not just by the ICB, who are saying they're listening, and maybe they are, but I think more local people and more GPs, probably from the LMC, need to be involved in drawing up those proposals that are then published for people and GPs more generally to read and understand, because what has happened has led to huge distrust of the ICB. And thank you, Debbie.
No, you're well. Can I just clarify? Because I wasn't at the meeting on the 20th. When you say that wasn't the same, what I've said and what they've said on the 20th varies, what is that in particular?
Look, just to say,
We are
that because it was a residents forum and lots of questions were asked around what were the different options around the different models. Obviously, that was the approach in terms of describing different ways and how different areas had worked. It wasn't talking about one model. In fact, they mentioned lots of different, as you said, there was a virtual hub and there was a different. Once again, the challenge is that we're saying we're trying to ease and help, some of the clarification by making it worse sometimes by some of the messaging and thinking that that's exactly how it looks. So absolutely understand that. It's trying to get the balance right.
I don't think there's a balance to be got. I think it needs to be withdrawn, and it needs to be said that it's being withdrawn, and there is a new proposal on the basis of what's come up, that there are multiple options that
and that was said on the 20th because I was there. It was, and I agree.
It needs to be quite differently presented. As I've said, there's a major issue of
this is
trust.
absolutely.
There's a major issue of trust.
Yeah.
And I've looked closely twice for my sins at what I found was a pretty appalling meeting where residents were told they couldn't discuss things. They could ask a question in 1 minute.
So I'm just keen to note, and for the purpose of people watching, I'm keen to note what's the action from this conversation, this particular one. So is the message going to be clarified? Are you going to be withdrawing what was proposed before? Are you going to put out a clear message that is consistent as well? Because there seems to be conflicting information from one place, from the other. So I'm keen to know.
To make a recommendation that formally body asks the people who put the proposal together to withdraw the proposal as it stands. It's caused anger, obfuscation, distrust. Even when people in the ICS come forward, as they often do, with good proposals, nobody's going to believe them in future unless that's done. Now, the second thing is that new proposals go up in clear English. With all respect to that, I wouldn't use words like journey, it's Chaucer, etc. Use clear propositions. Third, clarify that over a period of time, it needs to be sufficient period of time that practices with their patients, not just the GPs, whom I very much trust, by the way, with their patients, talk about access, what's wrong, how to improve them, how they might work in a different way if necessary. They go up straightforwardly as an option into which you can opt without penalty. That's quite important. If there's a financial aspect to this, I think on the new paper that you should say what it is so that practices and patients know the kind of money on the table and they know what they cannot access if they decide to go their own way. At the end of it, I think it's quite important because I'm quoting somebody, we'll make an informed choice for their practice. That was a sentence used, never mind who used it, about 10 minutes ago. Surely it needs to be the other way around, that practices working together or practices working with their patients, and it would depend, will actually make choices, and unless they're outrageous and way out of line, they will be accepted. So it's asking from the bottom that things be done, as the Fuller Stocktake said it, from the bottom, propositions of a practical kind emerge. And forget about using the very long language, which is quite interesting if you're interested in semantics, but on the whole is shut out language. So can we say that withdrawal, new proposals, time frame from the bottom, using all stakeholders, patients, local authorities and others, they go up as a new paper. It was what was asked for at JOSC by, I believe, a councillor whom I don't know, I believe from Westminster, said, please go back to the drawing board, think about it again, because you just got it wrong. And the chair of the meeting, whom I don't know well at all, endorsed that because councillors from both sides, who often disagree, agreed what was being presented was just not going to work.
Thank you.
That's
Jim.
a recommendation.
Thank you. So you've got some recommendations that you've put forward. Please tell us, what are your thoughts on those recommendations? What can you act on, please, and what's the time scale?
So I might just ask Linnell in relation to withdrawing whatever's on the website, because I don't know that from a central point of view. I think just in relation, so that's the first thing. So I think that if we need to take something down that is confusing, the practices have already had that. In truth, they've already had a letter. So every practice knows that we're not doing it like that now, that actually you will have an opportunity to do it in the way in which you feel fit for your patient. I think we can, for your patients, with your patients, I think we can commit that. So when you ask what the new proposal is, I don't think there is a new proposal. I think the new proposal is what we need to do over the next year to find out what the question is, what it is we're trying to sort out, and make sure that we have. So from my point of view, from a governance point of view, and I said this last week at the PRG, I think what would be great, we've got an access steering group now, we've got a North West London one, and we've got a local H&F one, which local authority colleagues sit on as well, as because it's not just about access to GPs. And I think what would be really useful is if we had a working group, you know, task and finish, whatever one wants to call it, where we did have the right people around the table to say, okay, what do we want to do in our PCN, in our practice, in our borough for, you know, this is the evidence, this is what the data is showing us, what do we want to do? So that's the proposal. So if you're asking that the proposal is we start again and we go back to the drawing board, then yes, we're committed to that. We're committed to that. So, you know, but Well, I think that depends on what's already on the website,
Yeah.
and that's outside my.
I understood that the website has been updated with new messaging and things, but I'll absolutely take on.
May I
take it back.
clarify?
Take that away.
That's really, if I may, Chair, that's really helpful. And I think there's a definitely, I feel as in Hammersmith and Fulham, as a cabinet member in Hammersmith and Fulham, I think our residents, if we follow what you've been saying, Debbie, our residents are going to develop with the GPs this improved access. I think the point you made very strongly, very interesting point. It may not be a problem with access, but the way used to get access, I'm fine with patches. So many of my older residents are not. I think patches works. Patches is completely counterintuitive to use. I just write, please call me in 14 places, and then they do. But I'm that sort of person. Most people aren't. So there are problems about access, definitely, in terms of you might be able to get access if you use the right system. So I love the way you've done that. I love the way you've described what we could do here in Hammersmith and Fulham. But I'm a little bit concerned, this is probably more for Linnell, I'm a little bit concerned that we will not be able to do that because the integrated care system is still pursuing the same-day access hubs plan. It's here on the website of the North West London ICB. It's still there. Dr. Genevieve Small discusses the ambitious plan the NHS in North West London is introducing to improve access to primary care for local residents. And all the things that you're saying, that Debbie is saying, all things that Debbie is saying about how we should, in a very democratic, transparent, co-producing way, which will build from the ground up and get something that everybody can buy into. None of it is there. And I'm concerned about the ICS here. I've said this long, I'm concerned about the way that we do things badly because we want to get them done in every place the same way. And the group of people at the center take decisions. And it's a new baby, the ICS. I want it to work. I want integration to work. And I want us all to get better healthcare. And I am concerned, however, that and I've made this clear to the chair of the ICS, I am concerned with the way that the ICS operates is a very top-down, Otomba way, which is totally unsuited to getting improved healthcare that we need. So is there a danger that although Debbie is going to lead a process with good people here in Hammersmith and Fulham, which will work well for us in improving access by starting off by identifying what the real problem is? And I read the newspapers like everybody else. There is a major issue about perception at the moment. Although in Hammersmith and Fulham we'll do that, are we going to be squashed by what happens at the ICS level, where there's going to be a certain amount of driving forward? I was in the meeting with Genevieve. She wasn't in giving mood, I have to say, the meeting that we had last week. And is it going to be driven forward anyway? And if it's not, you don't think it is, what can be done to reassure us all, starting by taking things off the site and making new statements of the way James provided? What can be done to reassure us that that's not going to happen? Maybe I can just ask, James, would you mind terribly if I ask Linnell to answer that, because she has an ICS capacity here?
Look, I think we're saying the same thing, and it's just that, and I absolutely take on board, and I think actually it's a really good point in terms of the messaging, where we're saying, this is the direction of travel. We really want to improve access, and we're going to do it at the local level, and it's going to be, and this is the direction of, this is what we've agreed, but it's still coming across as this is a new initiative that we're rolling out, and it's a top-down approach. And so even though things have changed, maybe we do need to refocus the messaging, maybe do another video that comes from a different angle so that we can get the messaging right, because we are saying the exact same thing. And even when I'm saying, well, there's a process where we're talking with GPs and around, how can we work together to do this? It's all around the same element of how do we locally lead this to get the best result with the limited resources that we've got across areas where there is variance, and how do we get the most benefit for our population that we're working with, but we've got to say it in the right way. And I think that's a really powerful lesson I think we've learnt quite strongly at the ICS over this process. Thanks.
I'm sorry, I'm still a bit confused. So what's specific action?
So there's no proposal to take down, which is why there's videos and there's messaging. So I think that one of the suggestions was take down the resident forum. The challenge with that is how that's perceived. And so I'll have to check, in terms of that, because, I think we probably need to get some probably patient advice on, what the best messaging and how we do that. But absolutely, it's a really the messaging, I think, is and I think that's where you can tell there's, we're doing a constant battle of trying to get the messaging right so that it gels and that it actually hits the mark, which, sometimes we think we've nailed it and then we haven't. So it is an element where we will keep working, and it's really good to get the input so that we can get it right. Thank you.
Can I just come in, because I think that's fairly unsatisfactory. It's unsatisfactory because we're told in this meeting at one point that yes, the plans that were there have been withdrawn. If those plans have been withdrawn, then the information relating to those plans on the website also needs to be withdrawn.
Couldn't agree more.
The apologies that are made at meeting after meeting, and as James has indicated, we are tired of hearing apologies and then seeing no change. Those apologies become more and more meaningless if the public presentation by the ICB-ICS does not change. There are two pieces, and I haven't looked at the website in the last 24 hours. There are two pieces by Genevieve Small, both of which need to come off the website. One is a very platitudinous, if you'll pardon my language, a very platitudinous presentation of how same-day access is going to be of wonderful benefit to us all. And we really ought to be really delighted about how this wonderful proposal is coming up that's going to do us a lot of good. And it doesn't say much else other than that. The other one is the recording of the meeting on the 20th of March, which, from what we are told today, particularly by Debbie, is now out of date. It is inappropriate, if that is out of date, for those things to be on the website. Further, it's inappropriate for some of the other papers that are on the website to remain there. If those apologies mean anything, then the apology needs to be followed by a paper that outlines the sort of proposals that Debbie says are likely to come into place for Hammersmith and Fulham. But other boroughs want exactly the same sorts of proposals in their areas. This is an integrated, and I emphasize that word, an integrated care system. And we cannot have a situation where the boroughs are going off, if you like, in a different direction, where some are being forced to have same-day access a la KPMG, and others are being allowed to rightly determine their own approach. I realise, Lynelle, that you're probably not in a position to commit the ICB, but I think we can ask that a very strong message goes back from all the people who are connected with the ICB here tonight, that if there is a change, it has to be a real change, and it has to be a public change that we can all publicly see, not just a letter going to GPs, but something that the public, that local residents, that patients can see, that campaigners can see, because we campaigners are the ones that let patients know far more than the ICB does. And that's a really strong message I want to get over to you tonight.
Thank you very much, Meryl. That's very clear. I think in terms, I mean, for me, it's important that you manage your expectations. What can you do, please? What can you do? And let's just be clear exactly what can you do in terms of next steps?
So we can take the message back very clearly from what you said tonight in relation to the communications on the website and making sure they're updated. And we can communicate your desire that there is a public apology and that you are called out as a team of people that managed to get the communication across to the public in a way that we didn't. We can certainly propose that. I'm not sure I have the authority to insist on it with the team, but I can certainly convey your message.
And I think from a Hammersmith and Fulham perspective, I think you can be assured that we will work over these next few months at pace to try and get what we want for our residents and whatever that may look like. So I think just to go back to Jim's point earlier around, what is the new proposal? I think the new proposal is we set up a working group to work this out. That's what the new proposal is. That actually let's move that forward now.
Can I just add one thing? Councillor Coleman is right. Don't want to declare UDI in this borough. It doesn't work like that. It's meant to be an interacting ICS. I believe in Ealing, something similar was said last week. They just didn't like it. They didn't buy it. There needs to be a rethink across Northwest London. I believe Westminster councillor, I couldn't see her properly, who said, look, whatever's good on this is completely unclear. Go back to the drawing board. An apology, it's a waste of time. It really is. I don't want it. What you want is some new thinking as to how we go forward together. That's the key thing.
If I can add to that, in the meeting, the informal ICP, we had all the councillors that were represented there, which was all the Labour councils and the Conservative councils of fewer, all said the same thing. They all said the same thing. And this is why I say that this is a test for me of the ICS, because it's meant to be integration, obviously, between the different parts of the NHS, secondary to primary care, but it's also meant to be integration across the councils and the NHS horizontally. And if what the councils say is brushed aside, and perhaps again, James and Linnell, this is more for the ICS than for Hammersmith and Fulham. If what the councillors say, whether they're from Westminster or Kensington, Chelsea, which is a Conservative council, he spoke up. I spoke up. Westminster, Hillingdon, they all did. If what we say is ignored about the way this should be taken forward, then what does it say about the ICS?
So I think it's been very productive. I just wanted to scope out a scenario and ask the committee a question. So we put together these discussion groups at PCN level and practice level about access, and practices don't turn up. And practices and their CDs decide, not interested, don't want the money, no thank you. Who has authority over how resources are used in the NHS?
I'd be actually interested, because there are two GPs in the room. I'd be interested to hear Kyla's views on what you just put.
So currently GPs we work on a GMS contract basis where we're given money per patient and we're asked to deliver a service. It's quite a nebulous, vague contract, to be honest. It doesn't say you must provide this number of appointments at this time. It has an opening time and a closing time, but you must provide a service to meet the needs of your patients. And I think that causes a lot of tension between practices and the ICS, because it's not a fixed sort of contractual thing. So there's other things that they can add on. You must make sure all your patients have a managed blood pressure. You must see all your mental health patients twice a year. So there's additional things that they've added on that we can be sort of contractually obliged to do and won't get paid for otherwise. But our core service is for a practice to decide how it runs that service. And I think that's where a lot of tension lies between practices and the ICS, that they would sometimes like to take more control over how a practice runs its service, but they currently do not have that power to do so.
That's very interesting. It is helpful, because I think the way in which primary care works in this country is poorly understood by people outside of primary care. What happens if you have in Hammersmith and Fulham couple of practices who really are poor, who their view of meeting the contract would not necessarily be their patients' view of how the contract should be met, but they never asked their patients. What can we do about that? I mean, who is actually able to change the way that they operate? If they don't want to engage on improving same-day access, or they don't want to engage on other issues, what should happen?
I'd ask Hassan to come and...
I wasn't, James, I was actually talking to Dr. Cranmer.
So I think there's lots of practices out there that do struggle for a multitude of reasons. And often when you look at the practices that are struggling, you'll look at an area where there's deprivation, there's health inequalities, and we need to think about those practices often in a much different way to give them support. Some areas, don't manage to spend their additional roles funding, and we need to look at, it needs to be a completely supportive approach from the ICS with those practices as to how they can improve that. As soon as you put in these sort of mandated top down, it's obviously the trust then is broken and people are less likely to engage. So there's going to be a huge trust rebuild now from the ICS.
This is interesting. So James, I will bring it back to you, because I don't know why coming into this whole thing about what can we do to make them do it. Well, you can tell them to do it and instruct them to do it, or create a situation that's just happened, which has gone so badly wrong. But it sort of takes, I don't know why, into my head came a conversation we had about 3 years ago when I was saying to you, why are the vaccination results for flu consistently extremely poor in this borough? And you said, well, some people just won't take it. This is pre-COVID. And I just thought that at the time, you and I would have a different philosophy on that, because I'm not sure. It's like people say people are hard to reach. I think if people are poorly reached, the onus is on us to reach them. Don't blame them for being hard to reach. That's the implication. So I wonder if with GPs, there's a way in which GPs are engaged with that needs to change. And there is an approach which the ICS has said, this is the approach, but it hasn't worked. So maybe there's a different way of engaging them, using GP practices themselves to work with others. A bit like, you get difficult kids in a class and they sometimes change their behavior when their classmates say that's out of order.
Yeah. So that's the entire PCN contract. We have a contract at PCN level, not at practice level, on top of the GMS contract and QOF. And performance on areas within that contract are judged at a PCN level to try and do exactly that. If this practice is struggling with this diabetes care for whatever reason, then the other practices within that primary care network have an onus on them to go and support them to improve their diabetes care. So you're absolutely right. We do that. We only have a small amount of the overall budget to use to do that, but it's a significant amount. And unfortunately, I think that the success of that, because it has been a success, I think probably gave the group looking at access overconfidence about trying to impose exactly the same model around access and saying this is a PCN contract, you have to sign it, if you don't sign it, you don't get this bit of the contract. And a lot of people were shouting, that's too fast, that's too much, it's not evidence-based yet, we need to stop. But you're right, we need to do that. I think unfortunately, the levers we have when we are trying to address lots of different areas of poor practice really are held at the national level if it comes down to a contractual. And we try and avoid the contractual because it becomes confrontational and acrimonious, and various different groups, including the LMC, will come in and it gets extremely difficult. What we always try and do, and Debbie's team are legion in this, we try to build up trusting relationships to understand why they're having difficulties in delivering diabetes care or offering access or whatever it is. And that's where I think we need to invest. I think whatever resource we have, we should invest it in building those relationships within the practices, with their patients, so that we can have a non-confrontational, non-contractual discussion about what the issues may be and how they can learn from practice elsewhere. And we are continuously doing that. And in fact, when you look at the diabetes care, you look at the mental health care in the borough and at ICS level, there's been a lot of success in moving things to a PCN level away from the practices to try and facilitate that co-working.
Jim.
I think what James said there is quite interesting because I can recognize that from my background in education. Some schools work very well, other ones less well, despite the fact they were in the same neighborhood. So schools learned to work together, so they learned from each other. The schools in this borough really have improved a great deal over the last 10 years, partly by doing that, with encouragement, by the way, from the council, from other people. One thing, actually, I'm trying to put together in my head where we got to from Debbie and yourself, and I think we're both being quite positive. If I understand it, there's going to be now a prolonged period, not too long, but prolonged nonetheless, of engagement with practices, with stakeholders, with patients, with whoever. Is that the case? But one of the things which comes in the paper was from the CEO, who said they couldn't really change things because things have been mandated nationally. But NHSE seems to have countermanded that in the last few days, saying, no, we're not imposing anything on anybody. That's from Amanda Doyle, who's way up the food chain. So do we really have a commitment from this meeting that you're going to go back up, or somebody will go back up to Marlborough Road and say, listen, Ealing, this borough, and I think other boroughs have got significant and fundamental concerns. We're going to plot from now on how we work together at practice level, PCN level, and so forth, in an encouraging way, but without mandating anything. Do I take that as what you're both saying?
Yeah, absolutely. I'm hoping for actually this to be a really positive step forward, especially with the patient engagement. When we say to practice, look, here's money to engage in a conversation with your patients about how they feel about access. Because at the moment, there isn't really a contractual obligation for them to do that. And we're not putting in a contractual obligation, but we are saying, look, the money is there if you want to have this conversation. I would point out, this is additional money on top of the single offer money, on top of QOF, on top of GMS, that our ICS decided they would invest. If by the end of the year, they look at this and go, this hasn't been a success, we haven't managed to improve access, we haven't managed to move the conversation on, doesn't mean people are moving to hubs, but we haven't got a conversation going, there's no guarantee that that money stays in access. Let's be clear, this is public money, we have to spend it responsibly. And if we can't continually facilitate a conversation about access with public money if we reach a dead end on whether or not practices are willing to change, patients accept and like the changes. And that is the biggest risk to me of all, because I do not think the status quo serves a significant proportion of our population.
Again, just for clarification, say a PCN working together with their patients, residents, stakeholders, believe that they actually do have good access, then they will be allowed to develop themselves. Because the original proposition, if I understand it, and I read all the papers and reread till I was certain, was KPMG driven. They came up with targets, with dates. There were hard dates there, I'm afraid, in print. Would KPMG continue to drive this or not?
So no, but I think you also highlight the very important challenge. How do we get to a version of the truth? How do we say, right, let's say our PCN, the patient's happy with access, we don't need to change anything. But you will have, maybe you have 5 vocal patients who will say, absolutely not, my access is appalling, you must change something. What is your measure of what is the truth about this?
That's not the way you do about it. In any consultation, any facilitated consultation, any discussion with people, you're not saying the 6 people in the room are going to vote against the other people. If you have confidence in them in what you're doing, in terms of you're involving people in a proper, inclusive way, sufficient numbers of people, they can do qualitative involvement in quantitative. There's a whole range of things you can do. But I think I don't accept the basic premise of what you're saying as something which suggests that we're going to be consulting appropriately. And so I think there's a whole way we need to look at involving stakeholders and GPs and others, and not just there are 6 people in the room saying they don't like it. It suggests the consultation hasn't been proper and authentic and worked properly.
We'd welcome your help on that, because I'm sure there will be it will be contested. Whatever the group lands, there'll be a particular group or particular facet of patients who say my access is still not serviced, and so we need to.
Well, I'd be very surprised. I would be very surprised. I think that you need to start off by developing a process with the people in a co-produced way, much as we did with the Disabled People's Commission and the work we've done afterwards on dementia strategy, the same sort of thing. I'm sure that Joe Beatty would be able, who's patiently sitting here, but is very closely involved in all that and works with Debbie, I know, would be very glad to help with that.
We've spoken at the beginning of a working group. Is this something that can take it to the working group as well?
Yes. So I think just to try and summarise, because I'm aware of the time. So I think just in relation to the commitment that you have got from H&F. So, and remember, there's not just me. So there's 8 of me across the 8 boroughs. So can you imagine that? 8 of me, 8 of me across the boroughs. So they've all been, we all are striving to do this. They're all having these conversations with their councils as well. So in truth, we do know the mistakes we've made, that the ICB has made, and we are part, we are the ICB. So I can't say it's them and me. It is a generic entity. However, I think that we have all heard our GPs in particular. So it's not just councils, it's not just patients. It is actually the GPs as well going, this isn't going to work. So we do need now to go to that drawing board. So from an H&F point of view, you have got a commitment that there will be a working group. That working group will involve different stakeholders, which will include the council, it will include patients. I think your point, Ben and James, just in relation to who that we may get different views, we will. You need to come to a PRG. You get patients in the same room saying completely different things. So that will happen. So we will need to be mindful of that when we're trying to come up with an informed stance about what we as H&F want to do within our borough for our access, and need to understand, I keep going back to it, but what is the question we're trying to answer? And the final thing I would just say is that there has been a line drawn under KPMG. So that bit of work, that they are not leading this moving forward.
Are they getting you more money for any work on this?
I don't know. Outside of my pay grade, I don't know. I genuinely don't know.
I would like to make a point in relation to this, because one of our members of the HASPAC, Keith Madison, who couldn't attend and send his apologies, he actually put a written statement in terms of the concerns that he had, and this is in relation to KPMG. He says, I also know that KPMG were involved in the program management at the time of financial restraint on the NHS. How can they justify the high fees charged by this company? Given that there is a top-heavy bureaucracy in place, the question is to be asked why no one in that team was capable of working this up without having to use external sources. Frontline services are being starved of funds, yet the bureaucracy continues to spawn and spew out so-called new initiatives instead of concentrating on safe, properly funded services and that people first approach.
If I may make a suggestion on that point, then, could we write to the chair of the ICB just to understand what the role of KPMG will be going forward? Because you use consultants for 2 reasons. You use them because they have an expertise which you lack, or you use them because you haven't got time to do something and they're going to coordinate it better. I don't know what the reason of using KPMG was in this case. It doesn't seem to, I can't imagine the expertise isn't there. The expertise is only, it's in the doctors, it's in the patients, it's in the community. So maybe they've been asked to perform a coordinating role, but I think it's important to understand if they're going to, is there a view that they're going to have a role forward and what the budget is for that? So maybe you want to take that up with the chair of the ICB.
Happy to say that, and also to include all, Councillor Wobie as well. She sent a brief statement. The same-day access to GP primary care issue is disrespectful. As I, a councillor and HASPAC committee member, found out about it through the weird Microsoft Edge news platform. So this is a message that I had agreed to pass on her behalf. So thank you very much for conveying our message. Thank you very much for agreeing to the working group. Thank you very much for coming this evening. I know you've had a long day and it's late at night, so I appreciate coming together and having the opportunity to discuss and for you to listen to some of the concerns that we have, that our residents have, that our stakeholders have, that the members of the HASPAC have. So I think in the spirit of collaboration and partnership working, I think it's positive that hopefully, yeah, we're taking some baby steps forward. So thank you very much. I appreciate it. Thank you very much. Okay, no, we've got agenda item number 5,
What's that?
work program.
Just say noted and everyone.
And it's now yes. Yeah.
Just say noted.
Each meeting, I've raised the issue about the work plan. Historically, we've always had a list of items that we're interested in that we would like to see come back to the PAC at some stage. We don't seem to be putting that on the agenda at all. It just never turns up. So could we possibly do that? It'll make it easier so that we can then say, if we've got mental health things, we can say, okay, that and that might be useful hearing it on the same night.
Yes, thank you very much. Noted, and I'll ask David to include it in future.
Yeah, and on that basis could I suggest, and I wrote an email to David, that we have another look at adolescent dentistry in the borough. Because I think it's a while since we've actually had an update on that, because we know that it's problematic.
The Health and Wellbeing Board discussed dentistry. That was discussed at the last.
Yeah, we had.
So that we have the one I wasn't at.
Well, yeah, it's online. You can watch it. It's sorry. I mean, we had a long discussion about dentistry.
Sorry, I didn't see it in the minutes.
Of this meeting.
There was health and
They haven't come out yet, but we.
The Health and Wellbeing.
They come out. They come out.
Oh, well, that's not.
We're in a long discussion about dentistry. I mean, the problem with dentistry is the dental contract's rubbish, and the government won't fix it. And that's the problem. If you really want to do something, you can't plug holes with sort of words. There are serious problems with it. So
with all due respect, I was asking it because I hadn't seen an update. Because
we had a long discussion about Health and Wellbeing Board, and
since I'm not at that and wasn't aware of it, all I am asking is, which is what you would expect.
Yeah.
If there's an area where I feel or anybody else feels we require an update, this is the appropriate place to raise it, because not everybody has access to these other meetings. So it was a genuine request.
I know the request, and would it be helpful if we
give her the link to the meeting?
The report, it's online, it's been recorded, and the report that was submitted for that meeting?
Yeah, but it may be there's something that could be added just to the minute saying this is actually of interest because it's been raised. That would be useful. And the other one was also on suicide prevention, because we talked about that at Health and Wellbeing Board as well. Sorry, Councillor Coleman.
Yeah.
Please, we have a councillor that's sharing the meeting. If she could answer, that'd be fabulous. It was raised before, we discussed it, but we didn't get any sort of follow-up. I know it's an extremely sensitive area.
I totally agree with you, Councillor Lloyd Harris, and this item was also discussed at the Health and Wellbeing Board earlier.
Yes, it was discussed at great length. Both discussed at very important issues.
Dr.
Lang is doing extraordinarily good work in this area, and it's a big challenge. But we discussed at the Health and Wellbeing Board. I think probably what would be helpful for you, if I may make a suggestion, an only suggestion, is that there are two areas in this borough. If you're really keen on health, which everybody in this room is, there are two places in this borough which discuss health matters. One is this PAC, one is the Health and Wellbeing Board. I have the pleasure of sitting through the meetings of both. Have a look at the agenda of the Health and Wellbeing Board and see if you think there's something. If you think there's, I'll just finish what I'm saying. Sorry. No, I haven't finished what I'm saying. But I haven't finished what I'm saying. No, but I haven't finished what I'm saying. I haven't finished what I'm saying. I haven't finished what I'm saying.
That is absolutely fine. I asked the question.
And my suggestion.
Check the meeting, please, both of you. I appreciate.
No, it is something that is, I brought it up here, so I would expect an answer here, or if we can attach something to it, because I don't get invitation to that panel or board. Others may, and that's absolutely fine. This is, I think, where we get a little bit of confusion.
Thank you for raising it. Can I please?
Councillor Coleman, you don't be offensive, please. That's not really useful. It was a genuine question. It was a genuine question. I don't raise things to be argumentative. I was trying to get some information. Our chair is answering it. That's all I was hoping for.
Thank you very much for raising it. It's noted.
Thank you very much.
Can I make a suggestion as well? And Rita, can you please help us? There's some information from the last Health and Wellbeing meeting. And can you please circulate with Councillor Harris the agenda for that meeting and the minutes of that meeting, if that's possible? because it's got a
That would
very
be
detailed
great. Thank you very much. No, that's fine.
You're welcome.
Thank you.
And the final item, dates of future meeting, please know the dates of future meetings. And finally, this is, I think this is our last meeting of the municipal year. So I want to thank all of you for your contributions the last year, and all your, the officers as well, for your fantastic work. Thank you very much.
Could we say thanks to the chair?
Yeah.
You've been
Yeah, exactly.
patient
Well
and
done.
democratic.
Yes.
Yes.
Very much. Thank you.
Yes.
Wow.